Thank you for the invitation for this Congress. For this last talk, we will be talk about what we're doing in Paris, about ECPR, my conflict of interest. Okay, just a story. What is the story of why we're doing that? It's not just we said, you know, we are crazy, we start something like, something, yes, I'm crazy, but anyways, it's not just that. It's a story, in fact. In 2008, as you know, Chen published in the Lancet, amazing. He treated cardiac arrest, in-hospital cardiac arrest with ECPR, and it's an amazing increase of survival rate, 40%. I'm a pre-hospital physician. When I seen this result, I said, okay, nice. I take all my cardiac arrest to the hospital under CPR, and we can start with ECPR, and disaster, we start some guidelines. The French society would like to do some guidelines, and they said the no-flow at the center of the guideline in 2008. The no-flow, we know, is probably the best criteria to know if someone will be survived. But if you do some pre-hospital care, you know, we never know the no-flow. Family said always the no-flow is 2 minutes. And when we are in ICU with a survivor, we speak with the family. The history is, I listen a noise, I go on the room, I don't know what's happening, I call my friends, he said call 911 and everything. Anyway, we have 10 minutes, and everybody's dying. And when we do these techniques with this guideline, we take patients shortly to ICU in hospital to do ECPR. This is a disaster. 2 survivors, 51 patients. In hospital, they said we stop. Too much money, too much energy. It's not ethical to do that for a patient. We transport someone with no hope. They said, we stop it. But I think it's too early. And we start to think about a little bit. Why Chen have 40% and we have just 4%? We have a problem. And this is why we start to think about why. And I think, first of all, we have a large misunderstanding of what is a cardiac arrest. Today we said cardiac arrest, it's just a sign. It's not the same from a STEMI, PE, or everything. 5 minutes after the cardiac arrest and 20 minutes after is not the same. And probably during the 21st minutes, the goal is a risk. We have to restart the heart very shortly, shock, CPR, good quality of CPR. But after 20 minutes, the chance to have a risk is so few. We have to change the mind. Change the arm. This is the brain we have to save. If the brain is always alive, we have no chance to have a heart restart. And this is why probably we have a misunderstanding. And we think about this problem, and we start with this physiology and said what we can do. First of all is where, when, and how to do. The how to do, you know, a lot of teams do percutaneous. The first paper was from San Diego in IED. But the problem is the failure rate is 20%. Because in cardiac arrest, it's not so easy. Movement, the flow in artery and venous is not so easy to describe. You poke so much time, sometimes you have a large hematoma after. It's not so easy. This is why we start to think about differently. And we would like to do an hybrid technique. It's not surgical technique. Why? Because we are very lower. We are, in fact, where you insert a central line in femoral way. We just open to check where are the vessels with a finger. And after, you can check where is the artery and the venous. It's really different, in fact. And we do a Seldinger technique, like we do every day with a central line. We don't touch to the vessel. We are not surgeons, just Seldinger techniques, but we know where we are. And at the end of the process, you see this is a grow. You can see we are very lower than a surgeon. A surgeon will be here, probably. But at this part, you have a lot of tissue. You need to be a surgeon. And you have all the movement of the CPR on the abdomen. Here, we have no movement, in fact. We are lucky. We can continue under CPR all the process. And for the surgical process, we need a surgeon. I don't know in your institution, when I call a CT surgeon to say, you have 2 minutes to come to do an ECPR, he loves. He never go. He do surgery. He's in OR. He have other things to do. And we have to think about the efficiency of the resources. Because if we take your surgeon, he cannot do surgery for something other way, other things. When, this is a question after, we have a large evidence now to say each minute we lose for ECPR, this is a death more. And we have a really correlation, and it's not new. Chen in 2008 described this curve. This is the survival and the CPR duration. And as you've seen, it decreased very shortly. After, when we know we have some rush to do, we have to know what is the limit. This is the first part of the problem. How many times I have to go in ECPR? In this publication in 2017, you have the survivor here. And if you've seen, they are always, or pretty always, under 60 minutes. We speak about the golden hour in trauma. We can speak about golden hour in cardiac arrest, in a refractory cardiac arrest too. Now we know we have 60 minutes between the cardiac arrest and the ECPR. But I explained at the start, we have a first phase, or the goal is the heart. How many times I have to do my classical resuscitation? This is a US register. After 16 minutes, you have less 1% of survival discharge to the hospital. If you see the title, when should we change to novel therapy? That means when do we start the ECMO? For other groups, it's 21 minutes. That means we have likely 20 minutes. We start T0, 20 minutes of classical CPR after you go in ECPR. It's very short time, 20 minutes, in fact. And this is why we think about where. If we see in different publications, this is the group of Vienna, 57 minutes to go to hospital when we have a cardiac arrest. Because in city, this is a real problem. Some of people said this is because you have a doctor on scene, he spends too much time. No, paramedics do the same. Why? Because in the city, the problem is not the distance, it's how to reach the hospital. In this flat, we have a cardiac arrest. This is an ECMO center just here. But to go outside, we need to take the firefighter. I'm sure it's not 20 minutes. In the city, we have a vertical limit and an horizontal limit. We have a major problem of horizontal limits in Paris. I don't know here, but to go to hospital, it's a real deal. And in France, the level of care in prehospital, this is a mobile ICU. That means this is exactly the same we do in ER. And what we think is hospital reach a patient. And if we do intubation, EKG, and everything, why we don't do ECPR? They do in ICU. We can do on the field. This is why we start a training program with surgeon, cadaver, mannequin, simulation, and we start to do in pre-hospital. The first step was a safety and feasibility study, a low number of patients, and what we're doing, we win a lot of time. We skip this red bar. The red bar is a transfer to hospital. And when we do this study, after we start a real implementation in 2011, and we are able to do everywhere, road, subway, supermarket. My colleagues like the Louvre Museum. About the Louvre, we have to discuss the Louvre. First of all, le radeau de la Méduse. This is probably my best picture for me. And le peuple guidant la liberté de la Croix. This is a major picture. But anyway, we are able now to do another picture inside. For the story, the people the more stressed in this story, This is the people of the Louvre, because they are afraid we split some blood on the picture. I never think about this problem, because if we need to pay this, will kill me. Anyway, this is in the train station. It's what's happening in the real life. We try to be more sterile we can. You see the CPR is automatic now because we are going in ECPR. We opening, we check where is the pulse, and we can opening. Today, the ECMO team is just 3 people. 1 physician, 1 nurse to do the priming, and 1 assistant. And you see, we just open the skin, and after, this is the finger, magical finger. And we can dissect with the finger. With the finger, we cannot do anything wrong. You cannot open any vessel or something else. And we check where is the vessel. And after, just we opening with some instruments the vessel to be sure where is the venous and the artery to separate. Because one of the major complications in ECPR program is the venous-venous cannulation. And we have sometimes, this is a major complication. And after we poke just, this is a Seldinger technique, classical Seldinger technique. And as you've seen, with these techniques, we never stop the CPR. That's a real advantage. We just check the guide wire, and after we just open the skin because the major problem is the cannula is very large, and we have a step inside the cannula to through the skin. We dilate. We don't touch too much to the vessel, just for the venous, we dilate the venous. After we have a little bleeding. And during the time, the nurse does the priming. The advantage of this technique is we have always the same time, in fact, and whatever the patient is, a fat one or a small one, where we are, we can do everything. It's not really surgical, you see. You push. It's hybrid techniques. Okay. Oh. A new time. Okay. It's not pre-hospital is not the solution for everything and for everybody. This is a paper from Dimitri Yiannopoulos in Minneapolis. What they're doing, they take the patient very shortly to the hospital, and they have some nice results, in fact. But if you check the results, it's 45% of survival, but this 45% is for this patient. And 47, they start at 72 patients. Because they start the care, they select the patient, they have some problem of insertion. Anyway, it's another solution. But what they describe, they said is they do a circle around the hospital. That means a lot of patients cannot reach the hospital in time. And in France, another team try to do this type, is Nancy, and they do a real protocol really to win some time in pre-hospital phase, to do the best they can. And before the protocol, 100 minutes, and now it's 80 minutes. It's better, but we are not in 60 minutes. Remember, in pre-hospital setting, we have some limit of extraction. When you are in this position, we have to do this stair. It's really complex. When you are on the last floor of a building, Arc de Triomphe, or on a wall, something else, the patient is here on ECPR, for example, or on the subway, it's a little bit hard to be on time on the hospital. Remember, this is when we start the selection protocol we have, and now this is, we work about the results we have. And what we find is when we have an asystole and no sign of life is breathing, gasp, movement, or muesis. If you have asystole and no sign of life, no survival. That means you can exclude this patient. No flow null, and that, you can exclude the patient. It's very important. This is the first time we can exclude a part of the patient with 100. And this is why we develop a new algorithm of selection. After 20 minutes of CPR with AED, we can select the patient. Sign of life during CPR, directly CPR, during cardiac arrest. Because if you have some sign of life, that means your brain is alive. Hypothermia, under 32, intoxication or general anesthesia, you can have a neuroprotection, you can go in ECPR. For other patients, is no major comorbidity, witness cardiac arrest with no flow less than 5 minutes. Less than 5 minutes, that means is firefighter is on scene, or people see the patient fall over and start immediately the CPR. We check the rate, shockable rate or PEA, ETCO2 more than 10, and we can be in 60 minutes or 100 minutes, it's acceptable. We can go in ECPR. The other patients are excluded. And what we're doing to win some time now, when we have a call for cardiac arrest, less than 65 years old, CPR is started by the first lay people. We go directly on scene, the ECMO team and the mobile ICU. And what we're doing, we win some time. Period 1 is when we're waiting 10 minutes before we leave the basis when the basic life support arrived. And period 2, we go directly, and you see we decrease the time always. And what is very interesting is, one thing, the time of insertion is significantly less in pre-hospital setting with the same team of physicians, because we are a very small team, just 3 people. When you are in hospital, we have a lot of people, residents coming, training nurse coming, everybody coming, and they are not so trained. But it's not just the ECPR, this is a global package, and we go to the cath lab very shortly after the ECPR. And what we find is very interesting, because we can have a start of the explanation why we have some patients in refractory cardiac arrest, because they have a multi-vessel lesion and very proximal lesion. This is why they never reopen with the CPR. They cannot restart with this type of lesion. What are the results now? We call the selection negative when we use the first selection. The protocol is pre-hospital ECPR, epinephrine max 5 milligrams, because 5 milligrams is 20 minutes of care, and direct angiography. If you have not the new selection and not the protocol, 3% of survivors CPC 1 or 2 at the discharge of the ICU. Selection, the new one, but not the protocol, 19%. This is the effect of the selection. It's very important to know, if you start a program, you have to select the patient or you kill your program. And when you have the selection and the protocol, you go to 38%. That's a very increase of survival. Remember, these patients have 60 minutes of CPR. Probably they are always dead if we don't do ECPR. Just, you need to optimize the chain of survival. ECPR, it's the last link, is here. If you don't do everything for the first link, you have a lose. And for example, in France, on my institution, we start by the ECPR, and just 1 month ago, we start, for example, an app for the lay people to go to do the CPR immediately. This is a global package of CPR. If you do ECPR, you need to increase all the level of care. The Paris programs is an adaptive program of what we have in Paris. We have a vertical limit and horizontal limits. We have a large medical pre-hospital system, and we have a large history of pre-hospital system. This is why it's not a major step to go to do ECPR in pre-hospital, in fact. And we have a medical dispatch. We can select at the call which patient can be selected, and we can organize the patient, go directly to the angiography, for example. And we are a non-profit system, medical system. That means we have no We have some problem of money, for sure, like everybody. But we have no problem of who need to build the ECPR. And this is why now probably the channel of survival in Paris is more this one with a new link. It's very important for us because now, for example, when a patient has a cardiac arrest, a lot of family ask us, he cannot have the ECPR. It's not possible today to have not ECPR in the care in France. We have to think about to have a program everywhere. Thank you, but to conclude, a link with the first talk we have this afternoon. For example, when we see, Simon said, when we have a terrorist attack, it's another subject, but we have the same history, past history. We have to be a team, and when we have a terrorist attack, it's really different, like trauma and everything. For example, this picture was, the people do that is Cabu. It's people was killed during the Charlie Hebdo attack. And he does this picture for the SAMU 1 month before he died, and now this is a symbol, for example, for us, of the SAMU of Paris. Thank you for your attention.
Thank you, Lionel, for this very interesting talk. Maybe there is some debate about this. First, I want to mention what you pointed out. There is not only just the selection, but also there has to be a system behind this ECPR so that everybody knows what would be going on if we start ECPR. And this is, I think, a major fact that has to be kept in mind if you want to start a program like this at your hometown.
We cannot start alone this type of program. When we start, we discuss with surgeons, with CT surgeons. They agree with us to do this. They are at the start opposite, but they see they cannot take care of this patient and they die every time. And they see if we don't change something on the time, it's not a good issue. This is why they accept the program. But now, for example, if on field we have a problem, we call, they are aware we do that, and we go directly in OR to repair what we have, if we have a problem of vessel or something else. Cardiologists are okay, we go directly to the angio, they stop the program and we go straight to the angio, but we do for all cardiac arrest. All firefighters are trained to know what we're doing, they prepare the patient before we arrive, and now they know nicely what we're doing. It's a real team.
Are there any questions from the audience?
So maybe I ask another question just to put this amazing work you're doing into perspective for us in Austria and the Graz, because I guess a lot of guys are sitting there and like, okay, this is interesting. How many people are living in Paris?
With one team now, we cover, because now we take the helicopter. I don't show the slide, but we go very far at 100 kilometers with the helicopter. And for people before have no hope to go to the hospital because it's too far, they have now a hope. They have 13% of survival with the helicopter. We cover probably 15 million of people with one team.
Okay, this is more than Austria has. I guess if we just double.
We do 60 to 80 by years, but it's not the number everybody needs to have. What is the number, what we're doing of the care of cardiac arrest? It's 20 years, we do CPR and AED, we learn, we not progress on survival rate. We have an opportunity to increase the survival rate. What is the price of the life?
Absolutely. Just another number. How many calls do you have a week?
By years, it's more easy. We have 1,000 calls for the team by years. We go outside 300 by years, and we do 60 to 80 ECPR by years.
Okay, so just divide this by the denominator in the beginning.
And we are very happy to go outside because what we see is the quality of care increase a lot. A lot. It's amazing because all the team, we have trained all the team, and they know a second team arrived, and they would like everything is clear. on scene, and very popularly. And the goal they have is to have a ROSC before we arrived, because we spend some time after. They go with us to the NGO, it's 3 hours. They prefer to have a ROSC, go directly to the ICU, it's really more easy.
So this is a placebo ECMO effect.
Yes!
I got this. And may I ask just another question? What is your bystander CPR rate?
It's 60%.
Okay.
60%? Yeah, 60% before the apps. Because all the dispatch center do CPR by phone, but we don't know the quality of the CPR.
Sure. Just for you in the audience, we are right now in Graz around, if you just how you document, and it's definitely the quality which is not documented there as well, but around roughly 22%. So just to put things in perspective.
For the number of standard cardiac arrests, we have 60% of CPR. We have more than half of one have a ROSC on scene, and we have 14% of survivors inside Paris, really downtown. We have a really increase of the level of care by the ECPR program.
Great system you're running. Any other questions in the audience? May we have a microphone?
Maybe you mentioned this and I missed it, but I'm curious. What's the success rate for cannulation with the percutaneous slash cutdown technique?
9% of failure of insertion.
9%
of failure.
Do you know?
This is exactly the same of surgeon.
and that's all that really matters. Do you remember what the rate was with percutaneous? You were doing percutaneous.
20% of
it was 20%.
Yeah.
So you lowered it by 10%.
And the major effect of this hybrid technique, probably sometimes you can be faster by percutaneous, but sometimes with this type of insertion, it's really constant on the rate and the time of insertion. And because we don't prime before the device, we have 10 minutes. Use these 10 minutes. We have no way to 3 minutes because we have 10 minutes to waiting the priming.
Okay.